more connections we can make, the better. So today, if you didn't know where you were, you're at the workshop for trauma responsive nurse educators, implications for workforce well-being, retention, and patient safety. And I'll give a little bit more history on this in a second. I'll test this, of course. So to begin, I want to give a big shout out to the Workforce Center and Kim. They put on actually support us for a grant from the University of Maryland School of Nursing, Maryland Workforce Center, and Kim is here with us today. Kim, would you like to say hello?
Hi, everyone. My name is Kim Hampton, and not only am I an assistant professor at the University of Maryland, but I'm also the program coordinator for nurse education and retention at the Maryland Nursing Workforce Center. I wanted to welcome you all here today, and I bring greetings from our director, Crystal DeVance Wilson, who is on a much well-deserved vacation. For those of you who know Crystal, you know, even when she's on vacation, she's still working. So she was already texting me this morning saying how excited she is about this. Wanted me to make sure that I give her a report when it's done on how. So before I turn it over to our wonderful speakers, I did want to share two things with you. First, all of you are going to be added to our Workforce Center mailing list so that we can make sure that we inform you of upcoming events. But also on your evaluation, please make sure, oh, sorry. So I was using my cheerleader voice, but also on your evaluation, please make sure that you let us know what types of further development you would want to see from us, because we do want to make sure that we're providing what you need to really thrive in Maryland as a nurse. The other thing is, and I'm going to use my notes a little bit, but the Workforce Center is partnered with the Maryland Action Coalition Retention Work Group and Lead Nursing Forward to conduct a study about keeping nurses in Maryland in their jobs. So we are asking that you do us an opportunity to hear about what you have to say about that and complete a survey for us. There is information in your folders on the left-hand side. There's a page that has a QR code as well as a link, because we would like to hear what your jobs are doing to keep nurses in your job, but also if it helps you stay in that position, and also if there's anything that you would like to see done around retention. We are asking nurses as well as nursing staff, so that includes CNAs, PCTs, CNAs, so please pass on the information to your nurse friends as well as your nursing staff friends. You'll have to curtail your excitement about completing that survey right now, because it does take about 20 minutes, and of course we have wonderful speakers, but please consider completing that during a break, during lunch, most definitely after you leave here. And don't forget to pass. So thank you so much. Welcome. I'm so excited about hearing the content today. I think it's novel but much needed. So thank you and welcome.
And I will put a QR code up to that survey at break, so you'll see it again. So, why we're here today, these two lovely ladies are actually my daughters, one of which is here today. We are going to be having a panel of new nurses, but why we're here. We're here for our students, we're here for new nurses, we're here to support them. I'm trying to repopulate the nursing workforce myself. I feel like I've done a decent job. I have 3 children, 2 of 3 are nurses or becoming nurses. I couldn't convince my son. I tried. He's gonna do digital forensics and cybersecurity, so maybe he'll keep us from being hacked at the hospital. That's what I'm hoping for. So just to give you a little bit of background about how we kind of came up with this topic or how we got into this. So as you know, like I work here at the Patient Safety Center. My background is I actually was a nurse educator, nursing faculty for probably 10 years. Was also doing work at the hospital in quality and safety. And right before COVID, I did go back full-time to the hospital and have been full-time in quality and safety since that point. I do still work in teaching residents. Like I work very closely with OBGYN residents and have taught adjuncts since that time. But, you know, during all my time teaching, we know how stressful nursing school is. I think we can all agree that nursing school is a stressful time. And we also know that transition time into practice, well, and frankly, nursing is just stressful for all of us. And Maryland Patient Safety Center has a program that they've been supporting for many years. It's called RISE. I don't know if any of you are familiar with that, but it's a program through Hopkins. It's a peer support program, and it supports nurses, physicians, healthcare workers after severe events. And so about a year ago or 2 years ago, I was working with our director of business and development who helps to kind of sell that program across the country, and they had a RISE meeting. And my specialty background is maternal child health. So this started in my kind of thinking around what happens in maternal child health after a severe event. When a severe event happens, a lot of times we stay within our own little world. We don't always reach out for help. We don't want to talk to people. We might just talk to our peers, but we don't want to reach out to maybe the EAP. We don't want to utilize resources because it feels uncomfortable, and sometimes it's not normalized at all within our units. And so we started talking about it in that space. I was just talking about it in my specialty and talking about with my colleagues about it. And so that grew into a program that actually Maggie and Tara, who you'll meet in a minute, and I are working on supporting perinatal nurse leaders in better understanding the trauma that their nurses and physicians are exposed to in their day-to-day work. But it doesn't just stop in the perinatal space. This exists in all spaces in nursing. And so we started thinking about that a little bit more, because through this work with the perinatal team, we did a lot of literature reviews and started to understand the significance of this problem. I don't know that I had quite wrapped my head around the number of nurses that were saying that they have PTSD, and not actually just saying it, but even when evaluated and assessed for symptoms of PTSD, they had it. And so we started to think, would nurse leaders work differently with their staff if they truly recognize how widespread trauma is among their staff? And then is that what is leading to nurses leaving the workforce? And I think we probably all agree that that definitely is a piece of it. And so we first started this about 2 months ago, I think, early September. We started with this class for perinatal nurse leaders. So we held a class here the beginning of September for all perinatal nurse leaders. It was physicians and nurses, and we did a very similar type of workshop. And it was so well received. They were just like, oh my goodness, this really hits home for us. It hits home with why we see our nurses leaving, how we feel are we meeting their needs? How as leaders can we do better? But really it's hard for them as leaders too. We recognize that that's a struggle. So we started talking to Crystal and Kim about this and thought really about this as a continuum. There's things that maybe nurse educators could be more aware of because we're preparing them. And as we were talking to some nurses in this work, is there anticipatory guidance? Are there things that nurse educators could think about or prepare nursing students more for what they're about to see? Because we're not going to remove trauma from nursing. I mean, we can do better in a lot of things, but there's still going to be trauma. The bad things are still going to come in. We're not going to keep a patient, them having to see a patient that was just in a car accident. We're not going to remove that. But I think we might be able to do a better job in preparing them and recognizing that they are already coming into practice with their own personal traumas. And so how are we recognizing that and being a little bit more aware of that in our work and weaving that into what we do? So that's how this started. So this series, this workshop, sponsored by the Workforce Center, starts with you all. So you are our first workshop with the Workforce Center. We are going to be holding another one in March that is going to be for nurse leaders. So for nurse managers, assistant nurse managers, folks at the hospital. And then we're going to be holding another one after that for CNOs. So we are working up the up the scale, so to speak, of where nurses are interacting, because the CNOs need this, because the nurse managers need to some support. Like the CNOs need to know that nurse managers are dealing with their own traumas, like having to manage all of this and dealing day to day with people leaving and feeling the heavy burden. And CNOs have trauma. You know, I worked with so many CNOs who really feel so responsible for everything that's happening in that hospital and really struggle with that administrative burden of managing all of that. So we're just know that it's not just you all, we're working through everyone. And in no way do we think today is the end of this conversation. That's what I just want to be clear about that. I'm hoping that today just makes you start thinking about this in a little bit of a different way, hopefully. And we're going to try to provide some tools and thoughts around what you might be able to do to help, address trauma in nursing, trauma among nursing students. But I think that this is the beginning of what could be a lot more learning to come after this. So I don't want anyone to think, oh, we're going to give you all the answers today, because I'm not sure we have them, but we're hoping that we spark discussion, conversation, and some tools that you think are helpful in your work. So that, I just wanted to make sure you knew how we got here, that this wasn't just some like random, like, oh, we were gonna throw this together and wanted you to all come. We've been thinking about this for a while. So this was a quote that came from the Surgeon General. The nation's health depends on the well-being of our health workforce. Confronting the long-standing drivers of burnout among our health workers must be a top national priority. And I think it's not going to be a one-size-fits-all approach. It's not going to be like some Band-Aid approach. We have to start really from the beginning and how we're educating our teams, and then everybody needs to be involved, and that's really the approach we've been taking. And I know I'm in a room with all nurses, and for me, one of the things that started me thinking about this when I was first working with the RISE program is I know that each of us can think back in our career, and there is an event or events that we still carry with us, that they walk around with us, and you can remember moments of them, sounds, things that happen, people in the room, and they're still with us no matter 30 years later. I as I'm saying this, I get goosebumps because I can still remember the people and the things that went on. And so, and as a person who spends most of my time in the quality and safety space, when I come into a hospital or an organization after a severe event, and they might be bringing me in to talk to them about what can they do better, how can we make a better system, how can we improve the process, often the people that were involved in that event have gone. They have left because they were so traumatized by what happened that they just have to get out, and they're leaving nursing. And that's sad, because we know that we should be supporting just cultures, and maybe they were supporting that, but the trauma was just too much for them to carry. So again, I don't know that we can remove all trauma from nursing, but can we help people to manage some of that better, how we respond, the tools we provide to do better, because it's just a lot to carry for all of us for our careers. And so I started thinking about this more as my daughters got into nursing, and helping at as they've been managing some events that they've been exposed to. So I think it's something that can be helpful to everyone. So today's objectives, we are going to, I have to say them, we're all educators now. If I didn't say them, I wouldn't be in an education session. Identify the impact of trauma on nursing students and its downstream effect on quality, safety, and workforce. I don't know that I ever really put all that together. I knew trauma, but I didn't necessarily always put the dotted line or the really direct line together on what this does to workforce and how it impacts quality and safety. Tara is going to come in today, and she's going to share with us some debriefing strategies and anticipatory guidance that nurse educators can use to promote well-being, resilience, and post-traumatic growth among nursing students. And we might have a discussion about the word resilience. We have a lot of do we say it? Do we talk about it? Do we not talk about resilience? Is it good? Is it bad? I don't know. We're going to let Tara tell us about that. Create a toolbox for nurse educators to build a psychologically safe learning environment for nursing students through trauma-informed communication and interactions, and describe how nurse educators can role model trauma-informed communications and foster a supportive educational environment for nursing students. So that's what we hope to get out of today. That's me. I already told you about me. I've been a nurse for 25 years. Most of my career has been maternal child health, but I've spent time doing education in that space, and now I'm in the quality and safety space. And my colleague Tara, come on in here, or you can talk in a little microphone. I feel like I'm like one of those TikTok people.
Thank you all for being here. I share more about myself in detail during my speaking presentation, but I just kind of wanted to thank Adrian. I am the executive director of Debriefing the Front Lines, and when I was first beginning this, I called Adrian and I said, hey, I have a really wild idea. I think I'm going to offer debriefings to just the workforce, and I don't know how I'm going to do it, but I'm going to post it on social media. And basically, Adrian validated that that was needed and it wasn't like a crazy wild idea in my mind. And she helped me formulate it and get it on paper and really helped me birth Debriefing the Front Line. So my friend, thank you so much.
It's my job to help people birth stuff.
Yes. Yes, and just on behalf of myself and Adrian and Maggie, we wanted to invite you today to be present for yourself, both personally and professionally. We invite you to notice, discover, ponder kind of what arises within you today as we have these difficult conversations. And I think the most important piece of this invitation is that together we invite you to be relentlessly honest about the facts while still remaining hopeful for the future. I'll talk to you guys soon.
And we matched.
Yes, we do.
Was not planned.
You did not bother tell me.
But she feels sad. Okay, here's my friend Maggie.
Hi, y'all. So I'm Maggie. I also have a perinatal background along with Adrian. She also has been a huge supporter of me and my works in founding a nonprofit. We're partners. We focus a lot in trauma-informed care within the perinatal space. And so a lot of my education to professionals and to clinical providers is around how we're bringing trauma-informed care into both our patient care and into our interactions with our colleagues and each other. And education, I'll talk more about it in my presentation too, but it really is like y'all are the foundation, whether you are working in academia, forming up, new undergraduates, whether you are working in clinical spaces as nurses, transition to practice. Like this is such an incredible opportunity we have to better prepare the rest of the nursing workforce to come in and work alongside of us. So I'm just really excited to share more with you all about what I've seen, what I've learned about the nervous system and how we can kind of tune into that a little bit more in our work. So thank you for being here.
And we promise we're not going to talk about birth all day today. I know for my non-perinatal people, they're always like, really, Adrian? Talk about that all day? No, we promise. So I go first, and I'm just going to really talk about the background here. I'm going to really just, my job in this presentation is to lay the groundwork, the foundation, get you thinking, and then my colleagues, Tara and Maggie, are going to get into the details about what you can do. Mine is just really all the things I've been pondering related to nurse education in particular, and how it impacts workforce well-being, retention, and patient safety. So we're going to talk about the impact of nurse turnover on patient safety and quality. You already probably know that it's a problem. Discuss what it means to be a trauma responsive nurse educator. Like, what does that even mean anyway? So I just want you to put on your thinking caps. During my presentation, it's not interactive. It's really me just kind of talking to you about what we think the problem is. But I'm hoping that my presentation gets all these kind of ideas in your head so that when Maggie and Tara come up here, you have a lot to say to them about what you're thinking about this topic. So thinking caps, engaged. So the current state of nursing, which I'm probably going to be giving you statistics that you already know, but positive things for new nurses, there are a lot of annual openings. You can find a job. So that's really positive, because I remember when I started, that was like the late 90s. I actually had to come home every weekend working at a hospital. I worked at St. Joe's then, and so that I would hopefully have a job opening for me when I finished, and they saved a job for me and I got it. Now, you can pretty much work anywhere you'd like. And And that shortage is expected to continue over the next decade. The total supply of RNs, though, decreased by more than 100,000 from 2020 to 2021, the largest drop that ever observed over the past 4 decades. So that's pretty dramatic. You know, a significant number of nurses leaving the workforce were under the age of 35, and most were employed at hospitals. So every hospital that I go to, so, you know, I'm out and about, I'm at hospitals across the country, and pretty much every single one talks to me about the challenge of new nurses. New nurses are a challenge, you know, and I sometimes get a little bristly about that, having new nurses. Like, I'm like, they're great, they're enthusiastic, you know, they're here, we're lucky they're coming, right, frankly. Be happy that they showed up, people, like, put a smile on. But then they're also concerned about their orientation programs. You know, they're like, we're trying to bring them up to speed, and that we know now that we probably in this room all have different feelings about nurses in specialties versus nurses starting in a med surg unit. Like, we all probably have different thoughts about that, but they have to start in specialties now because they need nurses there too. And the orientations for those are quite extensive, you know, to orientation for the operating room, orientation for labor and delivery, an orientation for an ICU, you know, could be 16 weeks to get through that. And so how those orientations may not be as strong as they once were, because we know about COVID, some things kind of maybe degraded, and also just trying to get new nurses training new nurses is another issue. So the hospitals do feel like this is one of their top quality and safety issues. I will also say that ECRI, if you're familiar with ECRI, it's like a leading quality and safety organization. Every year they list top 10 patient safety issues. This year, for 2024, they listed transitioning new clinicians to practice as the leading patient safety issue. And so I did hold a presentation about that for all the patient safety officers. About 100 people attended. They were from hospitals. They're feeling this. So, you know, this again just kind of reinforced to me as, how do we get them to stay? You know, and stay can mean a lot of different things. You know, it can mean, okay, hey, I'm staying in nursing. I might just be going on to a graduate degree. Okay, that's still staying in nursing. We didn't lose you. We didn't lose you to go to, you know, cybersecurity or marketing or something like that. We still kept you in nursing. So how do we keep them as, you know, excited about this as all of us are? I'm assuming you're all. So current state of nursing, this is from an article that was also about implementing leadership in trauma-informed care, especially in the emergency department. 87% of the nurses they surveyed felt burned out, 84 were frustrated with administrators, felt they were underpaid, felt that their mental health was suffering, 77 unsupported in their work, felt unappreciated. So these are bleak statistics. Uncomfortable having to work out of their comfort zone. I hear that a lot. Because of the low staffing, they're being pulled to other units. They work in other units where they haven't been really fully trained to. And for those of us that have done that before, it's not the greatest feeling to be there. And especially when you're new. You know, it's one thing if you've been a nurse for, you know, 10 years and you're like, have to go to the other unit, you're like, okay. And you don't mind speaking up or saying what you have to say. But newer nurses recently off orientation and being pulled to another unit, and it's happening, which makes them want to leave because they don't feel safe. You know, when you don't feel safe, it's not something that you want to do. And then 58% of nurses have felt unsafe at work, and I think that can be both unsafe, like physically. You know, we know that workplace violence is increasing. We're actually preparing to embark on a public service announcement that's going to be talking about workplace violence, and we have nurses that are going to tell their story and to encourage the public to understand, like, it's unacceptable. Like, you can't come into the hospital like this. So it is funded from the legislature. We had some money, and so we're working on that campaign now, and I'm thinking in the next couple of months it should be coming out. So this is some more data about retention. Latest data show that 900,000 nurses, almost 1/5 of all RNs in the United States, plan to leave the profession by 2027. Leaving their first position, this is the one that was surprising to me. About 18 to 25% of new nurses leave their first position within the year, and 33% leave within 2 years. And maybe that's not surprising to you, but it felt a lot. Issues were most pronounced with nurses with 10 or few years of experience, driving an overall 3.3% decline in the US nursing workforce in the past 2 years. And we know the cost is significant. So for hospitals, this is a huge cost, about $62,000 to train one nurse, you know, especially in specialties where they're taking multiple types of training, you know, for the OR, they're in lots of specific classes and training, ICU, ACLF, you know, fetal monitoring, whatever. It's a lot. And, you know, the other thing is training all these new nurses is burning out nurses that have been there for a long time. It's stressful to have someone that you're training. And so then you have that tension as well. You need someone who's prepared to be able to train the next nurse. And it's a lot, especially when you have somebody who's usually really good at it. You know, there's usually a couple of people on the floor who are really good at training, or will say yes to it, and they keep assigning it to that one person, and then you hear they're starting to burn out from having to do that. So now here's where the trauma comes in. So nursing students may be exposed to traumatic stress during nursing school, such as the stress of workload and clinical experiences, and I'm sure you all would agree that your nursing students are exposed to a lot of stress. Some manage it maybe better than others. But they can be exposed just because, you know, it's a lot of work to manage, feeling like they're concerned about keeping their seat, if they're gonna fail out of something, you know, if they don't score the grade that they needed to. And then in clinical experiences, I think we can't discount trauma that can occur during a clinical experience. They're being exposed for the first time to these really traumatic things in clinical. It could be the first time seeing someone naked. I distinctly remember that for the first time you walk and you're like, whoa, well, that's weird. I didn't expect that. Or like the first time that you're caring for someone who's actively dying and you haven't, or even for me, like I was an only child, so I didn't have all kinds of like baby experience. Going in for the first time and you're gonna like touch someone's baby and you're gonna carry it and you're afraid you don't drop it. Like it's very stressful. Giving someone an injection for the first time, like, oh my gosh, this is a lot. You know, and they may not seem like that big of a deal, but it's a lot of stress to just take on that you want to do good, you want to do the right thing. And so clinical experiences can be stressful. And so this was an interesting thing, and I know it's something that Maggie is very interested in. And Maggie will give a shout out because Maggie is actually working on her PhD right now, and specifically around trauma and trauma-informed care. And so this one, many nursing students have been exposed to trauma prior to nursing school. Okay, we can get that, but this is where I am like shocked. Nursing students have a higher baseline childhood trauma ACEs score versus the general population. Over 40% of nursing students versus 12.5 to 13.3 of the general population have an ACEs score of 4 or more.
Wow.
So we are taking, you know, your students are coming to you and have this and have trauma that they've already been exposed to. So they're coming in, we have them in a stressful profession, caregiving, with stress of I think we can all say the most stressful major, right? She lives like when she has friends that are like, you know, in another major, she's like, they're sweating about doing like math, and I have 97 ATI things to do. So it's a different type of major, right? And so you have students that already have significant levels of trauma that they've been exposed to that are now most likely at home still managing much of that trauma. I mean, when we talk to our students and the things that they have going on at home, like separate from what we're already they're going through. So is there something that brings this type of person into nursing? Is there something that leads us here? I don't know, Maggie might share more about that, but just want you to think about that we already have students that have significant levels of trauma, that as nurses, if we were seeing you in our clinical space and we were talking, we would probably address that. We would talk about the social determinants of health and what's going on through your life and how maybe to manage those things. But now we're laying added stress on top of that. So nursing education may result in trauma reactivation for nursing students. Nursing students' learning and well-being may be compromised by critical incidents and unexpected traumatic events occurring in the clinical environment. So we need to be really conscious of when we're taking our students to these clinical environments, we're talking about these things in our classroom, which we have to, right? I'm not saying not that we can't talk about these things at all, but we may have to be more thoughtful about what the students sitting in our seats may have already experienced. So how this, like in the perinatal space, one thing that we talked about is if you're a perinatal nurse and you experienced a stillbirth and you have to go into work and care for somebody who experienced a stillbirth. If you're a nurse and maybe your family member recently died of cancer and now you're caring for a patient that has that. You have students in your classroom who are experiencing those things, and then we're talking about these things intimately, or they're going to take care of those patients in the clinical setting. It can be traumatizing for them. And so as clinical faculty, as nursing faculty, we just need to be aware that we're talking about really sensitive things that aren't talked about in many other majors, you know? In other majors, you're not talking about math or teaching a classroom or those type of things that are very different than the intimate type of things that we discuss. Okay, so trauma in healthcare, what is it? So we'll all kind of define this a little bit differently, just so you know, we're all slightly different in our definition. But experiences that overwhelm an individual's capacity to cope. Trauma responses can be triggered in the workplace by emotional scars that we had previously, like stressful professional experience, increased workload, a terrifying event. And that terrifying event can be something that affects the person directly or indirectly, like on your unit, this happened. So trauma doesn't have to be something that happened just to the person. It could happen around them and they're still have trauma from that. Trauma after the pandemic, we know that had a lot of impact. Deaths or injuries that involve like significant blood or suffering, they're kind of imprinted, or workplace violence. There's others, but there's also physical impacts from this. So trauma on healthcare workers or on our students can manifest in things like headache, social isolation, anxiety, depression, emotional volatility. So, you know, I just want you to be thinking about this, like when, let's say you're meeting with a student and maybe their performance in clinical hasn't been so great, or they just did really poorly on a test and you're like, what is going on? And you're meeting with them to just review the test. Recognize that there could be other things at play here that are deeper than just, you know, whether they studied or whether they didn't, which I'm sure you all are aware of. But these are things that can impact nurses leaving a job and can result in things like addictive behavior, suicidality, and also impacts our ability to provide good care. Yes.
They have a validated like trauma screening tool for nurses or education.
Yeah, are you talking about that later in talk about the screening tool? So we actually talked about this in our perinatal course. There's a Breslow tool, and there's also like a PTSD, like just assessing for PTSD. It becomes kind of complex, right? Because if we gave that to our students and then it is very you know, sensitive information, right? Like, what are you going to do with that? It's a hard thing to know if we can screen for something like that, because if we do, then we know something about them that's very sensitive and might someone use that in an inappropriate way. So I wouldn't say that we should be screening for that widely. It's something that we see in research, but definitely something to consider, I think, and talk about and bring light to in our conversations with our students. But I'm not sure that the screening for it and then having the data, because how that's used, I think, is very sensitive and it could backfire. So I would just be really thoughtful if that was something that you would be. So, you know, I think that we've seen that in some places that there is a disconnect between how different the real world of healthcare is compared to the shelter of nursing school. And so I put it into AI because it's my new friend. I don't know if you guys know. I'm like obsessed by it now. Like, what is ChatGPT going to say about this? So I put in how vastly different is the real world of healthcare and the shelter of nursing school, and see what it said. So it told me that, you know, nursing school was a controlled setting versus the chaos of healthcare. that in nursing school, we have supervised practice, and then in healthcare, we are required for independent decision making. So stressful that we have to be independent then. In nursing school, we have individualized scenarios versus in healthcare, we have complex realities where we come in and there's all these different patients with different levels of complexity, and we have to figure out what one we're going to see first, and this one's yelling over here, and where do we go? Whereas in nursing school, we usually have one scenario that we have to take care of, or one patient that we have to take care of. Time management challenges, whereas in nursing school, you have dedicated time to complete your tasks and all your paperwork versus managing multiple patients with complex tasks and complex decision making. And then we have the issue of interpersonal dynamics, which, you know, in nursing school, this is definitely impacted. We still have interpersonal dynamics in our clinical groups. Sometimes there's drama, but definitely navigating much more complex relationships with patients, families, and unfortunately other nurses sometimes, which can cause further stress. So this is not for discussion, this is for that thinking cap. Do you think nursing students are adequately prepared for the trauma they will encounter working in nursing? So we're gonna get to this later, we're gonna have some conversation, but just to start thinking about like the trauma, you all have been in nursing, so you know what we can be exposed to. Are they adequately prepared? And I've heard from, you know, nursing faculty that that's stress on you all. Like, how can we really prepare them? And we know what's out there. And like, are we preparing them or well, I know what I'm about to set them loose into. That's all, you know, can be stressful to think, you know, I've heard all these things, I'm out there now, I see what it's like, these poor, like, gentle folks about to go into that. But we also know the great things about nursing. And that's what we want, you know, how great it is to be with patients, how fulfilling the career is, how much we love it. And that's what we want to be able to continue also to extend to them. So transitioning to the clinical setting, previous trauma exposure and workplace trauma can exacerbate this stress. So it's stressful anyway, becoming a new nurse. But you know, if that statistic holds true, that 40% of nurses have the ACEs 4 or more. And if you're not familiar with ACEs, it's Adverse Childhood Experiences Score, and it looks at things that that folks have been exposed to in their childhood, like includes things like divorce or substance use or abuse. And so understanding that 40% have had 4 of these or more is pretty dramatic. So we know that when they're transitioning to the clinical setting, that things like they're concerned about medication and practice errors. And frankly, new nurses, they do have more medication and practice errors, and they're stressed about that. And so when they have these, how are we supporting them through that, teaching them through that, you know, creating a just culture? That is really on, you know, the folks on the hospital side, but just helping them to understand that we, as nurses, we're working in a system. We're working in a system that unfortunately is prone to errors. How can we make that safer? And really supporting new nurses and understanding what are things that promote safety in nursing. They're caring for sicker and more complex patients. They feel increased stress during this time period. They're exposed to workplace violence, and missing support systems. I want to put an exclamation on the missing support systems because one of the things that I think as nurse educators and nurse educators in the hospital that I think we should stress is really this importance of them connecting with someone when they start in their new role. I know we have nurse residency programs, but you don't always connect with the people that are like, I don't want to say forced around you, but like, you know, your mentor isn't always the person that they say, this is your mentor. It's the person that you just find in your life, right? And so when they transition, I think one of the things that's really important for us as educators to tell them is find your person. Find your person, whoever. This might be someone who's been a nurse for 40 years. This might be someone who's been a nurse for 1 year, but find your person. I remember driving home after work and I would call that person and we would just have to debrief every day, just everything that went on. I have to talk through the whole day, you know, because I had all this like just feelings. And you come home and you have your family, but they don't really understand, you know, what went on. I mean, they're like, oh, interesting. Great. That sounds good. You know, like that's a little gross. Like, but I mean, having someone to to talk with about this thing, like, I think I forgot to do this. I mean, I can't tell you how many times I had to call back the unit and be like, did I sign that? Did I do that? Did I write that? You need someone like that. And I don't know if in today's environment with like all the texting and the socials, like that's as common as maybe it was. So, and I think that's just a good life lesson for anything. I know I tell everyone that who's getting a PhD, like you need to find your person in your PhD program, and like they hold you accountable and they help you and they keep you sane. And I think it's the same thing for nursing, like find your person and lean into them and let them lean into you and actually connect in that way. Because I think it helps you to process. It's just something that is just the day-to-day trauma. There's day-to-day trauma, and Tara's gonna talk a little bit more about like the difference between we think often as trauma as the big serious like event that happened, but it can be cumulative over time. Like the big event maybe was like, oh yeah, that was a lot, but it might be 3 weeks before we really feel like that big event hit us, because in between then we had all these other things that would keep piling on top. So, we know that our new nurses, as they transition into the clinical setting, they may lack confidence that's needed in some situations. They may tend to hide their emotions from colleagues or conceal their feelings of inadequacy. So you might try to overcompensate. And we've been hearing this in some other things we've been doing, because we're rolling out this debriefing initiative. And one of the things that folks have talked about is feeling like I can't really show how I'm feeling, because if I show how I'm feeling, people are going to think I'm weak. Yeah, well, I'm a crier, so it's not, it can't be held back. I might cry today, who knows? It's like I don't keep that in. So I think that we have to have some kind of conversation with them that you're not weak if you ask for help. We have to figure out how to normalize that. And that's why we want to talk to nurse leaders and CNOs, because that has to become something that's normalized within all of healthcare in order for us to keep nurses in place. And that support actually needs to be, we have to have support for them. It has to be good support, not just like fake, like, oh, we have this little supportive service over here that no one's ever used and it's actually not helpful. It has to be actually robust support that meets the needs of the healthcare workforce. But it's okay to have emotions, and it's normal to feel like you're not meeting the mark. I mean, I'm sure many of us still feel that way. I mean, I still feel that way. So mismatched expectations, like what you thought it was going to be versus what it is. And I feel like that's some of where, we all come in. It's not going to be shiny every day, and that's okay. Some days are going to be great. You're going to have this amazing patient. You love them. You gain so much from them. It was so fulfilling, and then the next day, oh, the classmate that blew off the patient. Like it's a roller coaster, but that's normal. But really understanding that that's what they're going to go with, and how to foster relationships to help get through all of that. And one thing that new nurses in this study that I shared here, that they have reported challenges with communicating and collaborating with physicians, and they've experienced bullying and harassment from coworkers. So it's one of those pieces where, from a patient safety perspective, that I really like to focus on is team steps training. I don't know if you embed that at all in your work anywhere, but I feel like team steps is really helpful with that. There's lots of resources, and on the flip side, nurses at hospitals, so like training, preceptorships should embed team steps, because I think it helps to give them communication tools like the cuss words and lots of other strategies to communicate very clearly, and that can help with some of this. So I'm just going to start by giving you the key tenets of a trauma-informed care, and then Maggie is going to get more into this. But the trauma-informed approach acknowledges that organizations, so I want to be very clear, it says organizations and individuals need to have a complete picture of a person's life situation. And so when we're talking about trauma-informed care, we talk about it a lot. Hospitals talk about it all the time. Oh, we're going to be trauma-informed in our practice with patients. If the organization is not trauma-informed, then it's really challenging for nurses to be trauma-informed with their patients. The leaders need to be trauma-informed with the nurses. The leaders need to be trauma-informed with the staff. The policies need to be trauma-informed. So I bring this up because as you're going back to your schools after this, you can be trauma informed with your students, but your school of nursing, college of nursing, department of nursing needs to have policies that support that. We know that sometimes our policies are a little challenging. I don't in any way mean that this means we just become loosey-goosey. That is not at all what I mean. But having policies that support understanding that students' life experiences are varied and that things go on. I'm going to give you an example of this, and I'm going to use Tara's example. So Tara lives in Florida. Recently, as you know, there was a massive hurricane in Florida that wiped out lots of homes. People were significantly stressed. During this time, obviously, nursing schools were underway. They had clinicals, they had things going on. And so that was a significant hurricane. That wasn't just like a little wind that came through one day. And so Tara does debriefing and connects with lots of people, and she has people that are clinical faculty, and she got a text from one of the clinical faculty that said she didn't even know what to do because her school continued clinical and required the nursing students to get there. And she said they showed up, they had no electric for like a week. They hadn't eaten, they were sleeping in their cars because they didn't have access to anything, but we still held clinical. Now, the hospital were probably like, what the heck are these nursing students in here? We got, we're on black, we have all these different things going on. And so I understand that things need to keep going. But could we maybe have thought, okay, if your house doesn't have power and hasn't had it, you can have off today. And we will, we'll figure something out later. And okay, if your house does have power, you come, I'll be here. We're not gonna hold this against you that you didn't get to clinical that day. And so that's just a kind of like I think an extreme example of how just sometimes we just need to be a little more thoughtful that different people are encountering different types of life experience. And especially when we know some mass disaster happened like that. How are we, what do our policies say? Can we be flexible in those things to account for things like that? And not have some poor, student show up that has been sleeping in their car because their house doesn't have any electricity and they don't have any food. So she, this instructor had a lot of internal strife. Like, I want to let them go home. Like, I want to let them go and try to fix their issues. I want to feed them. Can we take them down to the cafeteria and get them food? And so that was stressful for the instructor. So how as an organization, could they have maybe been a little trauma informed and say, hey, your families, everybody just got hit by this hurricane. What does our policy say about this? And that way it gives the instructor to be able to have some flexibility or have considered that situation ahead of time. So that's just like a high level example of like how being trauma informed at an organizational phase versus just an individual. So there's 4 R's to trauma informed care: realize, recognize, respond, and resist. So these are the 4 foundational R's, and Maggie's gonna go over this again, so you will hear this all day. So realize, and hopefully by the statistics that I gave you already, you're at the realize part. So realize the widespread impact of trauma and understand paths of recovery. So realize that your nursing students are coming into your classrooms with trauma and that nurses are exposed to trauma. And so that's the realize part. So the next part is, as an educator, you should be able to recognize the signs of trauma in students, other faculty, so in each other too. Like this isn't just about our students, this is about each other. We're all struggling too and have lots of stress as faculty. Believe me, I know. It's a lot of like ethical decisions and feelings and things that are going on. And it's hard. I remember the first time I had a class and I had to fail people. That was like so stressful for me. It was so stressful because I felt like I was ruining their life. They told me I was ruining their life, but they may have told me, they did tell me that. But and telling me all the reasons that I was, but that's heavy. That's heavy for faculty. So recognizing this within our students, but also within each other. And then here's where it gets a little higher level, right? We probably have to realize, and we probably will get to recognize, but the respond. So how do we respond? So responding by integrating knowledge about trauma into policies, procedure, curriculum, and teaching practice. So one part of this is just going to be as nurse educators to make sure that we are embedding this information into our teaching practices. So like teaching nursing students about trauma-informed care so that they're aware of this when they talk to their patients, but also teaching nursing students about some strategies about their own mental health and their own wellness. And then resist re-traumatization. So resisting re-traumatization by recognizing how maybe our classroom or our department or organizational practices or policies can trigger trauma histories or cause trauma. So these are the higher level ones, the respond and resist. So this comes from the CDC, it's from SAMHSA, but so there's 4 tenets and then 6 guiding principles of trauma-informed approach. And to me, this like overlaps like perfectly with like safety culture and like just culture. They're like exactly mirroring each other. So 1, safety, trustworthiness and transparency, support, collaboration and mutuality, empowerment, voice and choice, and cultural, historical, and gender issues. So, thinking about these are the things that guide a trauma-informed approach. So how do you create psychological safety in your classroom and in your interactions with students, in clinical setting? Are you trustworthy and transparent? Like when you say that these are the certain policies that you're having, can your student expect that this is what you're adhering to? This is what's going to happen. Peer support. So do they feel like the classroom, they can get support from each other? Collaboration and mutuality. Like, do they feel like they're a collaborator with you and with their other peers? Feeling empowered and being able to, share concerns with you. And I think that's something that's really powerful, right? It doesn't mean you're always going to say yes to everything that they say, but it should be that they should be able to say, hey, you know what? I was really concerned about X in the syllabus or this on the test. And you don't have to say yes, that I agree with you. You can say, no, I thank you for bringing that to me, but this is this is where I came up with that. And then cultural, historical, and gender issues. And that really ties into all of our work around diversity, equity, and inclusion. And so trauma-informed care really supports our work in diversity, equity, and inclusion as well. And so first thing, I think the lowest hanging fruit to start is that if you haven't already, really working to embed trauma-informed care into your curriculum. So there is a gap in knowledge among nursing students and healthcare providers. I've done some research in this in the OBGYN side, and the majority of OBGYN residents were largely unaware of trauma-informed care practices, and there are a lot of resources out there. I put some links to those in the PowerPoint. I can send them to you as well. But I think the first step is really helping nursing to change the practice. So we can teach them about trauma-informed care within our curriculum. How to teach students also to manage and prevent compassion fatigue, burnout, and secondary traumatic stress. I mean, that's a whole nother skill, and maybe that's woven into, different places within your curriculum, maybe in our foundations course, as well as in our, mental health courses. And in a qualitative study of nursing students, it revealed three themes around as they started to understand the importance of trauma-informed care. They had a growing self-awareness, so they were more self-aware of the importance of trauma-informed care, that it did fill a learning gap for them, and thinking about how they would thread this into their future role. So we want to embed this into courses across the curriculum, not just a one and done, not just talk about trauma-informed care once. It doesn't mean that they have to be experts in trauma-informed care, but threading this theme into each course. And it's a pretty easy fit, because we should be doing this with all patients in all populations. So, we're not the first people talking about this. It's not talked about widely in the literature, but we're not the first ones. There was a couple of recent studies, trauma-informed education in nursing, a call to action, and the minority nurse talked about this, that, they're really appealing us to start embedding trauma-informed principles into nursing education. And really, this just came out hot off the presses in November 9th, implementing a trauma-informed approach in undergraduate student clinical education. So I don't know how many clinical educators we have here, but if you're coordinating a course, I would recommend bringing this back to your your clinical nurse educators, because they spend so much time with those students. And they all have get to have the fun relationships with the students. So, I think definitely bringing them into this is important as well. So what we know, this was about college students in general. So we're digging more into the education side of it. College students often experience severe psychological distress. This was crazy. 70% in this study reported severe psychological distress. 35% of students were diagnosed with anxiety, and 29 had depression, and that was from the American College Association. And traumatic stress, so just so you are thinking about this, when you're meeting with students through advising or test review, it can result in difficulty learning concepts, focusing, or retaining information. And I know that I can very clearly envision a conversation I had with a student who had initially done well on a test, and then we started to see the test scores just get less and less and less and less. And I'm and I had talked to her the first time, oh, I got this, I'm gonna be okay. Then finally the next one we meet, and she really does start to share and open up about, her struggles with anxiety. And she got connected with the help that she needed and got to our testing center and got with her therapist and all of those things, and then started to do great again. But I think it's really encouraging students from the get-go to say, hey, listen, if you have, have had challenges with these things before, nursing school is stressful. Make sure that you're talking to your family, talking to your friends, talking to your colleagues, come talk to me, whoever, if you start to think that some of these things are peaking back up. Because they tend to not want to acknowledge, we can make it through, we can make it through. And then we start to see poor performance. So we do see that this results in course failures, high attrition rates compared to peers who have not experienced trauma. So knowing that 40% have ACEs of 4 or more in nursing, most have experienced trauma. So another question for yourself, do you think in your current practice that you practice trauma-informed care when interacting with every student? Again, just for you to think with your thinking cap on and start to think about examples of how you might live that in your interaction with your student. And then maybe thinking from what I've already said, some ways that you might be able to weave this in. With quality and safety, when we talk about anything, we think about what we can do now, what we can do near, and what we can do far. So now, meaning when you go back to your classroom on Monday, what can you do now? Something easy that you can just start doing that's going to help thread some trauma-informed care into your practice. And then maybe the bigger things are talking as a department. How do we look at our policies? Just bringing it to a faculty meeting and saying, okay, do we think that our policies are trauma informed? Or do we think we might need to start looking at them through a different lens? I know that in the hospital setting, we've talked about this a lot and what our policies look like supporting patients. So an example I can give, late policy, the late policy in an office. In an office, we usually say something like, if you're 5 or 10 minutes late, maybe 15 minutes late, we cancel your appointment. Is that trauma informed? We've had a lot of conversation about that because, there's patients that are taking multiple buses to get to a location, bringing multiple children. And then they're, 15 minutes late and we're saying, sorry, you can't come in anymore. Now the office still needs to run. So I understand that. But at the same time, did we use some individual thinking, this patient really just tried to get here? Does this need to be a blanket thing? Can we use a little bit of critical thinking here? So thinking about those things related to your department policies is how we get to the point of it being trauma-informed, being organizationally informed and implemented. So this was interesting. If you haven't seen this already, they call it TIEP, Trauma-Informed Educational Practice. A lot of it is starts to be referenced at the elementary school level, but you can see it starting to thread into higher education. So this term was coined by Corello and Butler in 2015 and describes educational practices that follow trauma-informed care principles in higher education. Reduction in stress, traumatic stress, and improvements in resilience and a trauma-informed climate were seen where it was implemented. Strategies that people had used to kind of get to this end were mindfulness and meditation were being embedded into classes. but there's little research in this space. So any of our researchers out there, if you're looking for something to do in your spare time, this is something that there's a gap. So what does it mean to be a trauma responsive educator? I titled it this. What does it mean? It is not about treating or diagnosing mental health disorders. I'm not saying that you need to do that, but it provides educators with tools, strategies, and skills to engage with students in a bit of a more meaningful way and recognizing the trauma that they're bringing into the space. The idea is that it's going to help to disrupt continuums of harm and to implement policies that can mitigate those harmful effects, and hopefully foster an environment of psychological safety. And that's really important because we want our students to feel comfortable to ask questions. We want our students comfortable to feel comfortable to come to us if they're experiencing a challenge. And really, this all, like I said before, it supports diversity, equity, and inclusion. So as I mentioned, the 4 R's, you should be able to recognize trauma at the individual level, at the group level, and at system levels. And you have to not only intellectually understand that trauma impacts people, but also think about how do we integrate that into our practice. So that's that higher level, the 2 R's, respond and resist re-traumatization. So, we all love the Bloom's taxonomy and the higher levels and the lower levels. So today we're going to definitely try to get through those realize and the recognize. And then as you go back and keep thinking on this a little more as a group, as your department, you can think about how can you thread this through your day-to-day work and in your individual work through advising and meeting with students. So you're going to work to set up conditions for people in your care, so your students, to be safe from re-traumatization. And I'm going to also include each other, because I know that sometimes, we have challenging conversations with each other. So people in our care are our fellow faculty, as well as our students. And we want to work to dismantle any organizational patterns and structures that continue to perpetuate trauma within our organization. So I know this is very wordy, but again, you have all these notes. And if you want the actual slide set, like in big version, just let me know. I'm happy to send it to you if it would be helpful for you to take back to your department meeting. If you're like, hey, I went to this interesting workshop, let's talk about it as a group and see what we all think about this. I can send you the PDF version of it and you guys can use the slides. So number one, I would say, especially as we're bringing in new nurse educators, we have a lot of people coming into nursing education that may have not taught before. And so one of the things I think that might surprise them, where they may not be initially aware of, is the challenges that nursing students face. I don't know that when I was first a nurse educator that I thought that I was going to have to support the nursing students in managing so many of their personal challenges.
So true.
I don't know that I realized that. I thought I was just like, I'm here to talk to you about maternal health. Let's talk about all my favorite things, stages of labor, let's go. I didn't know that I was gonna, have students that told me about domestic violence that they were, having at home. The fact that, through that their partner had turned off their electricity, their mental health disorders, and how then I had to figure out, I can't just hear this and do nothing. I need to do something. In nursing, when someone tells you about the violence that they're being impacted by or the social determinants, you need to give them something. And so do your faculty all feel like they have the tools to be able to actually refer, support, do something about that? If they don't, that could be why the students aren't coming to you in the first place. If they think that you do you know how to navigate to your disability support center? Do you know who's your person over there that you call? Do you know about the mental health services that your university offers? And can you quickly get to them? What's the wait time to get into them? Is it long? Does it exist? So I think that those are things that as you bring on new faculty, even clinical faculty, because like I said, they're the ones who get to sit for hours with them and may learn things that we don't. I think that's a great thing just to think about, is how do we give them those tools to help to promote trauma and trauma responsive education. So trauma-informed educational practice, these are from a variety of different studies and what they called how an educator is trauma responsive. So First was that being aware of the challenges that nursing students face and incorporating practices that promote healing and mitigate harm. Trauma-informed educational practice is a mindset, okay? So we're gonna get in the mindset. And acceptance of diversity, including background, knowledge, skills, and life experiences, and an understanding that some of those life experiences may be varied and include trauma. Trauma-informed education provides a framework for a collaborative, relational, and trauma awareness model when working with nursing students. And then another one said, trauma-informed teaching and learning is an inclusive, learning-centered teaching methodology. And its foundation is an educator who's aware of the intersection of learner behavior, performance, relations, and coping. So that was all from a variety of different studies what they said trauma responsive educators were. So again, I just bring back to this photo because I think that trauma-informed educational practice grounds nursing in this equitable, inclusive, and culturally responsive approach. And really, these 6 kind of guiding principles support that. Like, we should be promoting a safe classroom. We should be promoting safety in our interactions with our kids. They shouldn't feel scared of us. You know, they should feel like they can come to us. Trustworthy and transparency. You know, I'll give an example that I didn't think was very trauma informed. So recently, and it's not in nursing, it's just in education in general. So recently, my son is new nursing, not new nursing student, just a new student in college. So first year. And he handed in extra credit. He was all excited. He's like, I did my extra credit, Mom, because, you know, I've been telling him since he was like in 5th grade, you always do the extra credit. So he does his extra credit. And his roommate and him are the same major and this other kid, and they worked on this extra credit together. Now it's math. Okay, so there's not really like a lot of different ways to do math. Like, you're arriving at the same, like, you know, answer. Like, it's so and nowhere in the syllabus did it say you couldn't work together. And this was extra credit. Okay, nowhere in the syllabus did it say you couldn't work together. So they worked together. They thought, hey, we're going to work on this together. It was the first week of school. So they hand in their math early, all excited. He's like, I did it. I handed it in. I'm going to get some extra points. This is good. So it's the Friday before Labor Day. Labor Day? Yeah, Labor Day. So they're gonna have off for a long time. And he gets an email from the professor that says, I need to see you in my office next week. That's it. No like explanation, no nothing. He is distraught. Calls me, I'm like not even like in town. He's like, I don't know what this is. What is this? Like, what did I do? Like, I just did my math. Like, I don't even know. And I'm like, I said, don't worry about it. There's nothing to worry about here. I said, it's gonna be fine. And it will be okay. So I'm like, just email him back and say, I'm happy to speak to you whenever, you know, whenever's convenient, just let me know. And no response back. So no response back. So a whole 3 days have to go by. Meanwhile, he's just so worried. So we had to put somebody through that. And then on, you know, the Tuesday comes, oh yeah, I'll see you in my office hours. Oh, hey, you just can't work in a group. And I can't give you the points for this. Okay. I said, whatever he says, just say fine, whatever. And he was like, did I miss this in the syllabus? No, I forgot to put it in the syllabus. So what happened? What happened to trust? What happened to safety? What happened to trustworthy and transparency, right? You know, let's just say it's lucky I wasn't having a conversation. I had many words that I would have liked to have shared, but you know, to me, it's like, okay, this is the first week. Yeah. The first week. And you made the faux pas. You didn't have it in your syllabus. Right. So, okay, maybe we should think about, like, what did that just set up? Now we set fear. We put a lot of drama. The relationship is broken, you know. So just an example of thinking, like, why did also 3 days? So you had to put someone, you got to think about who's on the other side of that email. You know, this is their life to them. Like us, we're like, oh yeah, it's no big, like, we're not really that worried about it. Like, to him, it probably was no big deal, but to the student on the other side, it was. So that's how this, you know, no empowerment, done. Like, he couldn't say anything. So that's where students, when we wonder, like, oh my gosh, students are out there cheating, students are out doing this stuff because they're scared. You know, it's usually coming from someplace. So just something to think about in our interactions. I liked this. This was from the Oregon. This is from Oregon, I think, like Department of Health. and they took the 4 R's and put it into this really nice little algorithm, talking about realize, you know, the intersections of inequality and trauma and how that impacts things, assumptions and biases, and brain science, and how like trauma impacts brain science, and that's the realize part. Recognize is, you know, being able to see that trauma impacts students' regulation and comes out in a lot of different things like maybe attendance, lateness, tiredness, you know, all of those things. And then, you know, here's the responding piece of how students can respond. Like sometimes when students do things, we feel a certain way, like, oh, that's making me maybe mad, maybe a little frustrated, like really having to realize in ourselves, that's part of it, what that student response is making us feel and how it brings us back to maybe something another student did to us like a year ago, 2 years ago, or maybe 10 years ago, like really our self-regulation. And really being able to think about our physical space, what that's set up like, and how do we maintain student engagement. So I thought that was a really, and the resource is very, really good. So coming to the end, like what does this look like? And you're gonna get lots more strategies today, but you know, what does it look like for us? Empathy, teachers really need to try to understand students' personal and social situations. We can't know about every detail about all of our students' lives, and that's not at all what I'm insinuating. But being able to just, you know, think through, you know, what's going on in our students' lives, recognize that students' actions are really as a result of their life experiences. And then our students come to our classrooms with really diverse life experiences. Thinking about accommodation, like what accommodations do students need? And I'm not saying that you need to know how to address all of those, but knowing where on our university campuses that we can send students to get the accommodations that they need to be able to be successful. Resilience, really emphasizing students' strengths. Everybody has different strengths, and how do we do that? Create opportunities for students to like be empowered and share in some decisions. So if there's any place in your syllabus or in your work, you can say, hey, do you want to do this or do you want to do this? Kind of like, you know, when we talk with our children, like people feel like when they're engaged in the work, they're more likely to do a good job. And then really social justice, teachers are aware and responsive of forms of privilege and oppression, and that can come through in our policies and as well. So key takeaways, just be thoughtful about things that can trigger traumatic stress in our students. Consider these things in our lecture. You know, we talk about a lot of really deep topics, and you know, understanding how they can come out. And so, you know, what might you want to do to make sure that students are aware of what's coming in lecture, and also in clinical, recognizing the signs of trauma in students. Really thinking about how we can continue to respond with empathy, kindness, and understanding, and then our self-awareness of maybe how we're feeling that day, because we have lives too that have trauma going on in them. And then, you know, I think this to me is really important. Curricular standards must maintain rigor. I am in no way saying that we are getting rid of the rigor of our curricular standards, but they should be able to incorporate flexibility into the design to assist students who are faced with trauma. And that was kind of the example I was trying to give related to the hurricane. You know, we need to hold students. They need certain clinical hours. They need to come to them. They can't just be late every day. That is not at all where we need to be. But I think we do need to think about when we have students that are experiencing these things. I remember a student, we were having a final. We're having a final, and the student comes up and she tells me, like, it's like a day before, that her mother had just died from colorectal cancer. Now the whole entire semester, she never once told me this, and then comes in, I said, you don't need to take this. Like I can give you, like, you know, we can have a hold on your grade, take a few minutes, just like, we'll wait a couple weeks and then you can come back. Like, this is not a big deal. I can work through this. No. My mother would want me to take this test. You know, I'm like, okay. I'm like, I don't really think that you should. I think you should take some time. But so I was completely unaware of that. You know, students have these things happening, and then sometimes we just kind of get brought in at the end. And I think from the beginning, we are telling students, please come to us soon when you experience something. Don't wait to this time, so that we can be aware and help to support you in this. So evaluate your department and course policies, consider if they're trauma-informed, consider ways to integrate trauma-informed, trauma-informed care throughout the clinical experience, as well as in your curriculum. There's ways to thread this through, I think, in every single course. Think about how you can maybe add some anticipatory guidance about what the real world is going to be like what they're coming. What does that look like without being so scary that we're trying to be like, oh, you don't want to go there. No, that's not what we're trying to say. But how can we give some anticipatory guidance? And a concept that we've been talking about, psychological body armor. Really interesting. You can search it. It's a concept that suggests that we can prepare ourselves to cope more effectively with the hard things in life. And this is a concept that came through people who lead first responders and people who lead folks in the Army or other armed forces, and talking them how to prepare themselves for what's about to come. And so I think some of that is translatable to the work that we do. And really also, and I'll put an exclamation on this, encouraging overall well-being, sleep, nutrition, and fitness, because the stronger we are physically, it helps our mental health as well. And so how do we incorporate that? We know during nursing school, many students lose that because they're so busy with all of the work. And so in the end, this is just the journey that we're on. First, trauma awareness. So that's where we're at today, right? For many of us, first time maybe really thinking about this too much. Then it's trauma sensitive, deepening our understanding and reflecting on your current practice. And then getting to that point where we're actually trauma responsive. So we're like putting these things into practice and then conducting maybe research and then leading it with others, leading it among our staff, leading it with your clinical instructors. And that's it. I am going to, if you want the actual PowerPoint, I'll get it and send it out to everybody who attended at the end if it could be helpful. And so I hope that presentation just started you thinking a little bit. My two friends will get much more detail about what's to come, and we'll give you many more strategies that are focused specifically on trauma-informed care. I'm also going to send you the link to this. We don't have time. It's about a 15-minute video, but it's a really interesting story. This could be something you could share at a faculty meeting. She is a expert, kind of a leading researcher in this area, and she talks about her childhood and how a teacher helped her out of her mother died, her sister died while she was in grade school, and what teachers did to help her really continue to be able to meet her learning goals. So I think we are at great